Welcome back to the Deep Dive. Today, we are stripping everything back to the basics. We are talking about the frame.
The literal scaffolding?
The scaffolding.
Yeah.
The thing that actually holds this whole meat suit, as they say, upright against gravity.
We are talking about the skeleton.
We are. But, in preparing for this, looking at the stack of research, specifically the chapter on bone mineral homeostasis in Katzung and Trevor's, and of course the corresponding chapter in Goodman and Gilman's, I had a bit of an embarrassing realization.
Oh, yeah.
I realized that deep down, I still think of my skeleton as chalk.
Chalk in a bag.
Exactly.
That's the common perception, isn't it? That it's inert, white, brittle. It's just there to keep your head from falling onto your chest.
Yes. But that view, it's not just a simplification. It's completely wrong. The picture that emerges from these incredible texts is that bone is wildly, wonderfully dynamic.
It's a living archive.
It's a bank. It's an endocrine organ.
Yeah.
And it's in a constant state of, self-destruction and rebuilding.
It really is a history book. It records everything, your hormonal signals, your nutritional history for years, any inflammation, and, of course, age. And the pharmacology we're going to get into today is really about how we try to edit or maybe preserve that history when the body starts trying to erase it too quickly.
So that's our mission today, to synthesize these two legendary texts. We've got Katzung, which, as always, gives us that clear clinical scaffolding. The what do I prescribe and when?
And then you have Goodman and Gilman, which just brings the molecular reasoning. It really gets under the hood and explains the why.
I have to say, Goodman and Gilman really brings the heat on the why this time.
Yeah.
The molecular switches it describes are just elegant.
They are, and that's where all the modern drug targets are. It's a beautiful story of scientific discovery.
Okay, before we dive in, we have to do our standard disclaimer. What we're doing here is building a conceptual map for you. This is a scaffold for your revision.
It is absolutely not a substitute for sitting down and reading the chapters yourself.
Please use this discussion to orient yourself. Get the big picture so that when you do read the text, all those details have a place to stick.
We're highlighting the landmarks so you don't get lost in the weeds, and there are a lot of weeds.
There are. So, to kick things off, let's orient everyone with the key takeaways for this session. By the end of this deep dive, what are the core concepts we want our listeners to have absolutely locked down?
I think we can boil it down to 5 main pillars today. First, the big idea of dynamic bone. Just getting your head around constant remodeling, not static support.
Okay, that's number 1.
Second is ion balance. Seeing calcium and phosphate not as commodities, but as these tightly regulated signals. Third, hormonal orchestration. So how PTH, vitamin D, and a few other players manage this whole system.
Makes sense.
Fourth will be the therapeutic levers. This is the pharmacology, how we intervene with bisphosphonates, antibodies, anabolic agents. And then finally, tying it all together with the clinical perspective, understanding things like fracture risk, adherence, and the very long horizon of benefit.
A perfect roadmap. So let's start with the first principles, the biological stakes. Let's not even talk about bone itself yet, but the mineral it guards. Calcium. Why does the body care so intensely about calcium? I mean, we all know we need strong bones, but the texts frame it as a matter of immediate life and death.
It absolutely is. And to really feel the urgency, you just have to look at one number, one of the most dramatic numbers in all of human physiology.
The gradient.
The gradient. The concentration of calcium outside your cells, so in your blood, in your extracellular fluid, is in the millimolar range, about 8.5 to 10.4 milligrams per deciliter. But inside the cell,
it's practically nothing.
It's submicromolar. You're talking about a 10,000-fold difference between the outside and the inside.
10,000 to 1. That's not just a difference. That's a dam holding back a flood.
It's a loaded spring. And biology uses that massive potential energy for one thing, speed, because the difference is so immense. If you open a calcium channel for even a fraction of a millisecond, calcium just floods in explosively.
And that flood, that's the signal.
That rush is the signal. It's what drives muscle contraction. It's what allows your nerves to release neurotransmitters. It's what makes your blood clot. It drives a huge number of intracellular signaling enzymes.
So if that gradient slips, if your blood levels of calcium drop even a little,
the whole system fails, or it misfires. If your serum calcium drops too low, hypocalcemia, your nerve membranes become unstable and they start firing spontaneously. You get tetany, those muscle cramps and spasms.
You can have seizures.
You can have seizures. Your heart can stop. It is a true medical emergency.
Okay, so that frames it perfectly. Serum calcium is the right now money. It's the cash in your wallet that you absolutely need to pay the rent this second to keep the lights on.
Exactly. And the skeleton in this analogy,
That's the bank vault.
that's the bank vault. It holds 99% of the body's calcium, about a kilogram of it locked away.
But here's the crucial trade-off.
The body prioritizes the wallet over the vault every single time. If your serum calcium drops, the body does not give a thought to the long-term structural integrity of your femur.
It doesn't care about your risk of fracture in 20 years.
It cares about keeping your heart beating for the next 5 minutes. It will strip the bank vault bare to fill that wallet.
That is such a critical concept for everything that follows.
Huh.
Osteoporosis, then, isn't really a disease of the bone just failing on its own.
No.
It's the consequence of the body successfully cannibalizing the bone to keep the blood levels of calcium absolutely perfect.
It's a homeostatic success that leads eventually to a catastrophic structural failure.
And of course, we can't forget the partner in this whole dance, phosphate.
Ah, phosphate. The unsung hero.
It gets much less press than calcium.
It does, but it's doing so much heavy lifting. It's the P in ATP, your fundamental energy currency. It's a critical buffer for the acidity of your blood. And structurally, it's the other half of the bone mineral itself. It joins with calcium to form hydroxyapatite.
That's the actual crystal that gives bone its hardness.
Exactly, but they have this tricky relationship, don't they? Katzung points out that while they are partners in crime in the bone, they are often antagonists in the kidney.
Right. What's that about?
It's about a dangerous chemical reality. In the bone, you need both calcium and phosphate to make the crystal. That's good. But in the blood, if you have too much free calcium and too much free phosphate at the same time, chemistry just takes over.
They precipitate.
They precipitate. They turn into rock. Not in your bones where you want it, but in your blood vessels, in your heart valves, in your kidneys.
That's metastatic calcification. A disaster.
A total disaster. So the body has to juggle them with incredible care. As a general rule, if you need to raise blood calcium, you usually have to tell the kidney to dump phosphate just to keep that solubility product in a safe range.
Okay. So the stakes are clear.
Right.
We have the bank vault, which is the bone. We have the wallet, the blood. And we have this dangerous partner, phosphate. Now let's talk about the management team. Who is running this whole operation?
It's a complex doldrum, for sure. Goodman and Gilman lays out this beautiful hormonal orchestration. But there are really 3, maybe 4 main managers we need to know. The first, and I'd say the most aggressive of the managers, is parathyroid hormone, PTH.
I always think of PTH as the crisis manager.
That's a perfect description. PTH is an 84 amino acid peptide, and it's released by the parathyroid glands. These are 4 tiny, tiny glands sitting behind your thyroid in your neck.
And their whole job is just to watch the calcium levels.
It's their single purpose in life. They have a receptor on their surface called the calcium sensing receptor, the CalSR. It's a molecular thermostat.
A thermostat, I like that.
When blood calcium drops, the CalSR senses that change, it relaxes, and the gland just starts pumping out PTH. And PTH has one single order for the whole body. Get me calcium now.
And how does it do it? What's its strategy?
It launches a 3-pronged rescue operation. First, it hits the kidney. It tells the kidney, stop peeing out calcium. Reabsorb every last molecule you can from the urine.
Step 1, conservation. Don't lose what you have.
Step 2, while it's at the kidney, it gives a second order. Dump phosphate.
Ah, there's that trade-off again.
Exactly. It knows if you're going to pull a lot of calcium into the blood, you need to make room for it by getting rid of the phosphate. You don't want the patient turning into stone.
Very clever. And the third prong, that's the bone itself.
The bone. The bank vault. PTH stimulates the release of calcium from the skeletal reserve. But here's where it gets really interesting, and this is a detail that Goodman and Gilman highlights beautifully. PTH receptors are not on the osteoclasts, the bone destroyers.
Wait, they're not? Where are they?
They're on the osteoblasts, the bone builders.
So the hormone that causes bone breakdown talks to the bone builders first. It seems completely backward.
It's a chain of command. PTH goes to the osteoblast and says, we have a crisis, we need calcium. The osteoblast then produces a molecule we're going to talk a lot about called rank ligand, which is the signal that actually wakes up the osteoclast.
It's an indirect command.
It's like the general calling the engineers to tell them to open the gate for the demolition crew. The general doesn't talk to the demo crew directly.
That distinction that the builder controls the destroyer feels like it's going to be really important when we get to the drugs.
It's everything.
Okay. Is this PTH the crisis manager?
Mm-hmm.
What about vitamin D? I feel like most people just think of it as a supplement, like a vitamin C tablet.
Mm-hmm.
But the texts are very clear. This is a full-blown hormone.
It is absolutely a hormone. If PTH is the crisis manager, vitamin D is the logistics manager.
Yeah, supply chain guy.
He's the supply chain guy. While PTH is scrambling to mobilize existing resources from the bone and the kidney, vitamin D is focused on bringing new resources into the system from the outside world.
From the gut.
From the gut. Vitamin D is the only hormone that significantly increases the absorption of dietary calcium and phosphate. Without enough active vitamin D, you can drink all the milk in the world, but most of that calcium is just going to pass right through you.
And the activation pathway is a whole story in itself, isn't it? It's not just eat vitamin D, get strong bones. It's a journey.
It's a metabolic relay race. You can make it in your skin from cholesterol and UV light, which is chemically fascinating. Or you can eat it in your diet. That's just the precursor, vitamin D3 or cholecalciferol. It's totally inactive.
So that form goes to the liver first.
Right. It travels to the liver where an enzyme adds a hydroxyl group. It becomes 25-hydroxyvitamin D.
And that's the storage form, right? That's what they measure when you get your blood work done.
Correct. They measure that one because it has a nice long half-life, so it gives a good sense of your overall status. But, and this is key, it is still not the active hormone.
It has one more step to go.
One more step. It has to go to the kidney for the final activation. The kidney has an enzyme called 1-alpha hydroxylase, which adds another hydroxyl group. That makes 1025-dihydroxyvitamin D, which we call calcitriol. That is the active hormone.
And that kidney step is the main control point.
That is the gatekeeper. And guess who holds the key to the gate?
It has to be PTH.
It's PTH. When PTH is high signaling a calcium crisis, it screams at the kidney, turn on the 1-alpha hydroxylase. Activate the vitamin D. We need more supply from the gut.
So they work in concert. PTH holds the line with existing supplies, and vitamin D goes out and brings in reinforcements.
Perfect partnership. And vitamin D also has its own built-in safety switches. When its own levels get too high, it provides negative feedback to shut down its own production and to shut down PTH. Nature is absolutely terrified of hypercalcemia, so the system is rigged with brakes.
Okay, PTH is crisis. Vitamin D is logistics. Who's the third major player in this boardroom?
That would be FGF23, fibroblast growth factor 23. This one is the phosphate specialist.
And interestingly, it's produced by the bone itself.
Yes, by the osteocytes, the cells that are embedded deep inside the bone matrix. This is part of that endocrine bone concept. The bone isn't just listening to hormones, it's sending them.
So what triggers its release?
High phosphate. The osteocytes deep in the bone can sense when phosphate levels in the blood are getting too high. Maybe you had a phosphate-rich meal, or maybe bone remodeling is releasing too much at once. They release FGF23 in response.
And what does FGF23 do?
It travels to the kidney and does two critical things. First, it forces the kidney to dump phosphate into the urine. It's a potent phosphaturic hormone.
Okay, get rid of the excess.
And second, it suppresses the production of active vitamin D. It shuts down that 1-alpha hydroxylase enzyme.
It effectively says, okay, we're full up on supplies, stop the shipments from the gut.
Exactly. It is the counter-regulatory hormone to vitamin D. It's all about preventing that toxic calcification we talked about.
Yeah.
It protects the entire system from becoming oversaturated with minerals.
It's such a beautifully balanced system. And finally, just briefly, there's calcitonin. Calcitonin seems a little dismissive of its role in adult humans.
It's the minor player, for sure.
Okay.
It's produced by the C cells in the thyroid gland, and it does the opposite of PTH. It lowers calcium and phosphate, mainly by inhibiting bone resorption.
But what's the reality check?
The reality check is this. If you surgically remove a human thyroid gland, and thus remove their only source of calcitonin, they don't develop massive hypercalcemia. Their calcium balance remains pretty much normal.
So it's not essential for day-to-day homeostasis in adults.
It doesn't seem to be. It might be more important in other species, like fish that live in a very high calcium environment, or maybe during pregnancy and lactation in humans to protect the maternal skeleton. But while it's a minor player physiologically, we can still use it pharmacologically as a drug.
Right. Good distinction. Okay, so we've got the management team. PTH, vitamin D, FGF23. Now let's zoom in from the boardroom down to the construction site. The bone remodeling cycle itself, because this is where the action happens, and this is where all the drugs work.
Exactly. The key concept here is that bone is never finished. It is never static. It is constantly being torn down and rebuilt in tiny little packets all over your skeleton.
And you have the two main cell types doing the work.
You have the osteoclasts, those are the demolition crew, and you have the osteoblasts. They are the construction crew, the builders.
Let's look at the osteoclast first. Goodman and Gilman describes it almost like this. this alien monster.
It is a truly fascinating cell. It's a giant multinucleated cell. It's derived from the same lineage as macrophages, the immune cells that eat bacteria.
Just designed to engulf and destroy things.
That's its heritage. The osteoclast latches onto the bone surface and forms what's called a sealing zone. You can think of it like putting a suction cup down on the bone.
Creating a little self-contained, sealed environment.
Exactly. Inside that sealed-off suction cup, it starts pumping protons. It pumps acid. It drops the pH in that little microenvironment down to about 4.
That's incredibly acidic.
It's strong enough to dissolve the hydroxyapatite mineral. It literally acid washes the bone away. And then it secretes enzymes, like one called cathepsin K, to digest the collagen protein matrix that's left behind.
So it just digs a pit.
It digs a resorption pit. We call it a Hauschup's lacuna. Then, after about 2 or 3 weeks, it undergoes apoptosis, it dies, or it just moves on. And then the osteoblasts, the builders, move into that pit.
To fill it back in.
They lay down new collagen matrix, we call that osteoid, which then, over the next several months, slowly mineralizes and becomes hard bone. This coupling of resorption, followed by formation, is the fundamental heartbeat of the skeleton.
But here is the critical piece of information for our listeners to really get. The demolition crew doesn't just show up randomly. They have to be summoned. And this is where Goodwin and Gilman just shines, going deep on the molecular switch that controls this whole process.
The rank-rank-RPG system.
Rank-rank-oblast.
It was the central dogma of modern bone biology. It was a massive discovery that unlocked everything. Here's how it works. The osteoblast, remember, the builder holds all the keys. It produces a protein on its surface called rank ligand, or rank ligand.
Rankel is the signal, the go signal.
It's the go signal. Now, floating around in the bone marrow are precursor cells. You can think of them as baby osteoclasts. And they have a receptor on their surface called rank.
Okay, so the ligand binds to the receptor.
When the rank ligand from the builder cell binds to the rank receptor on the baby destroyer cell, it's like a key turning in a lock. It triggers a whole signaling cascade inside that cell. The precursors fuse together, they become that giant multinucleated active osteoclast, they get that ruffled border, and they start eating bone.
So the builder literally activates the destroyer. It gives it the green light.
It does, but the body, being clever, built in a safety valve. The builder cell, the osteoblast, also produces a third molecule. This one is called osteoprotogermin, or OPG.
OPG, the protector of bone.
That's what the name means. And think of OPG as a decoy receptor. It's a soluble protein that looks almost exactly like the rank receptor. It just floats around in the microenvironment.
And what does it do?
It intercepts the signal. It grabs onto the rank ligand before the rank ligand can find the rank receptor on the osteoclast precursor.
It's like gum in the keyhole.
It's a perfect analogy. It's gum in the keyhole. It blocks the signal from ever being received.
So if you have a lot of OPG floating around, the signal is blocked, the key doesn't get to the lock. No demolition.
Correct. No osteoclasts were formed, but if your OPG levels drop or your NKL levels go up,
the signal gets through.
The signal gets through and the destruction begins. So really, the entire rate of bone loss in the body comes down to the ratio of rank AL to OPG. That ratio is the master volume knob for bone resorption.
And this explains postmenopausal osteoporosis so perfectly.
Exactly. Estrogen is a hormone that powerfully stimulates osteoblasts to produce OPG. It keeps that safety valve high. It keeps the gum in the keyhole.
So it's protective.
Very protective. But when a woman goes through menopause and her estrogen levels crash, OPG production plummets. Suddenly, all that gum is gone from the system. Rank ligand runs wild. It finds all those rank receptors. Osteoclasts proliferate, and you get that period of rapid, devastating bone loss.
That mechanism is it's so elegant, and it makes so much sense. Now, there's one more pathway we should mention before we get to the pharmacology, because a whole new class of drugs is targeting it. The Wnt pathway. That's WNT, pronounced Wnt.
Yes. If NKL is the master destroy signal, you can think of the Wnt pathway as the master build signal.
For the osteoblasts.
For the osteoblasts. When Wnt signaling is active, osteoblasts proliferate, they lay down more bone. It is the fundamental anabolic pathway for the skeleton. But just like with resorption, the body has a built-in brake pedal, a protein called sclerostin. Sclerostin is a protein that's made by the osteocytes, those cells deep in the bone, and its job is to inhibit the Wnt pathway. It's a natural brake on bone formation. It essentially tells the osteoblasts, okay, that's enough, the bone is thick enough, stop building.
So sclerostin is the body's own stop building sign.
It is. And the way we discovered this is just fascinating. It came from studying people with a very rare genetic disease called sclerosteosis. These individuals have a mutation where they can't make sclerostin. They are born without the stop sign.
And what happens to them?
They have incredibly dense, thick bones. They almost never break anything. It can actually be a problem because the bone can overgrow and start to compress nerves in the skull, causing deafness or facial palsies. But it taught the pharmaceutical industry a crucial lesson.
If you can block the stop sign,
You can restart the building process.
amazing. Okay, this is perfect. We have the targets, we have the acid-pumping osteoclast, we have the RNKL signal that activates it, and we have the sclerostin brake that stops building. Now let's look at the weapons, the pharmacology.
Let's start with the foundation, the absolute workhorses of osteoporosis therapy, the bisphosphonates, alendronate, risedronate, zoledronate.
These are the drugs that all end in sogranate. And Goodman and Gilman points out that their chemistry is actually quite simple, but very clever. They're designed as analogs of a natural molecule, pyrophosphate.
Right. Pyrophosphate is a natural substance in the body that helps prevent soft tissue calcification. Chemically, its core structure is a phosphorus-oxygen-phosphorus bond, a POP bond.
POP.
The chemists who designed bisphosphonates made one crucial change. They swapped that central oxygen atom for a carbon atom. So the core is now phosphorus, carbon, phosphorus, PCP.
And why does that one atom change matter so much?
Because that PCP carbon bond is incredibly stable, our body has enzymes, pyrophosphatases, that can easily break down the natural POP bond. We have no enzymes in the human body that can break the PCP bond. It is, for all intents and purposes, indestructible.
So you swallow this indestructible molecule, where does it go?
It has a massive, massive chemical affinity for calcium. So it gets absorbed into the bloodstream, it bypasses pretty much everything else, and it goes straight to sites of active bone remodeling, where it binds to the hydroxyapatite mineral. It buries itself in the bone matrix.
It just stays there.
For years. The half-life of a drug like alendronate in the skeleton is estimated to be more than 10 years. It essentially becomes a permanent part of your skeleton.
So how does it work as a drug? It's just sitting there, inert.
It sits there like a landmine. It just waits. When an osteoclast comes along to that particular piece of bone and starts its acid washing process, it dissolves the mineral, and in doing so, it inadvertently swallows the bisphosphonate that was bound to it.
It eats the poison pill.
It eats the poison pill. Once the bisphosphonate is inside the osteoclast, it finally exerts its effect. Specifically, it blocks a key enzyme in something called the mevalonate pathway. The enzyme is farnesyl pyrophosphate synthase.
The mevalonate pathway. Wait, that sounds really familiar. Isn't that what statins target to lower cholesterol?
It is the exact same pathway, but statins block it very high up at the rate-limiting step to stop cholesterol synthesis. Bisphosphonates block it much further down, and this downstream step is crucial for making these little lipid anchors that are needed for small signaling proteins.
Okay, we don't need to get too bogged down on the biochemistry, but what is the final result for the poor osteoclast?
The result is catastrophic for the cell. Its cytoskeleton collapses. It loses that ruffled border that it needs to seal against the bone. It can't pump acid. Its signaling goes haywire. And eventually it undergoes apoptosis. It dies.
So you are literally killing the demolition crew.
You are poisoning the demolition crew. You freeze the remodeling process in its tracks.
But because these drugs are so potent and, as you said, indestructible, they come with some really intense baggage. Kitsun goes into a lot of detail on the absorption issues.
Oh, the absorption is terrible. I mean, less than 1% of an oral dose of alendronate actually makes it into your bloodstream.
Less than 1%.
And anything in the gut can interfere with it. Calcium, in particular, binds to it and blocks it completely.
So if you take your alendronate tablet with your morning coffee that has a splash of milk, or with a calcium-fortified orange juice,
You have just completely neutralized the drug. It's useless.
so what are the instructions?
The instructions are rigid. You have to take it first thing in the morning on a completely empty stomach with a full glass of plain water. Not coffee, not juice, just water. And it's critical. You have to remain upright, sitting or standing for at least 30 minutes. No lying down.
Why the standing upright part?
Because if that pill gets stuck in your esophagus, it is highly acidic and extremely irritating to the tissue. It can cause severe esophageal ulcers, esophagitis. You need gravity to make absolutely sure it gets down into the stomach quickly.
That is a massive compliance hurdle for patients.
Yeah.
And then there are the long-term, rare, but very scary side effects. We hear a lot about ONJ osteonecrosis of the jaw and atypical femoral fractures.
These are the ones that really worry patients and doctors. ONJ is basically a condition where the jawbone dies and becomes exposed in the mouth, usually after a dental procedure like a tooth extraction. The bone just fails to heal. It's very rare in patients taking oral bisphosphonates for osteoporosis. It's more common in cancer patients getting high-dose IV versions, but it is real.
And what about the atypical fractures? This seems so paradoxical. A drug you take to prevent fractures is now causing them.
It goes back to that idea of bone as a living, dynamic tissue. Everyday life, just walking around, causes tiny microcracks in your bones all the time. Normally, the remodeling process, led by the osteoclasts, finds these little cracks, chews out the damaged bone, and osteoblasts fill it in with fresh new bone. It's a constant repair process.
But if you've suppressed the osteoclasts too profoundly for too long,
The repair crew is dead, or at least they're on strike.
so the microcracks just accumulate.
They accumulate year after year. The bone becomes frozen. It's dense, yes. It looks great on a bone density scan. But it's old and it's brittle, like a piece of old, dry wood. Eventually, it can just snap cleanly across, often in the shaft of the femur, with very little or even no trauma.
Which is why the current thinking involves a drug holiday, isn't it?
Yes, exactly. The guidelines now often suggest that after about 3 to 5 years of oral bisphosphonate therapy, we might stop the drug for a year or two.
And you can do that because the drug is still buried in the bone.
It keeps working for a while, leaching out slowly, but stopping for a period allows the remodeling system to just wake up a little bit, enough to hopefully repair some of those accumulated microcracks before they become a major problem.
Okay, so that's the old guard, the workhorses. Now let's talk about the modern alternative, the targeted sniper, denosumab. This is the monoclonal antibody.
Denosumab is just a brilliant example of rational drug design. Remember that whole rank-rank-LOPG system we talked about?
It's its central dogma.
And remember how OPG was the natural decoy, the gum in the keyhole?
Yes.
Denosumab is, for all intents and purposes, a synthetic, supercharged, injectable version of OPG. It is a monoclonal antibody that is designed to bind to rank ligand with incredible specificity and affinity.
So it just mops up all the rank ligand in the system.
It intercepts the signal, it catches the ball before the quarterback can even throw it to the receiver, it completely prevents the formation, function, and survival of osteoclasts.
So how does it differ from bisphosphonates in a practical sense?
There are a couple of huge differences. First, it doesn't bury itself in bone. It's a biologic agent that circulates in the blood. So it's given as a subcutaneous injection, usually just once every 6 months.
Okay, that's a big compliance advantage.
A massive one. Second, it is not cleared by the kidneys.
That's huge, because so many elderly patients with osteoporosis also have some degree of chronic kidney disease, or CKD.
It is. You can use denosumab safely in patients with severe renal failure, a population where bisphosphonates are generally contraindicated. But there's a massive, massive catch.
There's always a catch.
And this one is called the rebound effect.
This is the part that really scares me about this drug.
As it should. Because denosumab doesn't stay in the bone, when you stop the drug, or even if you're just late for your next dose, the effect disappears quite rapidly. The antibody is metabolized and gone within a few months.
And what happens then?
Well, while the drug was active, the body was still producing rank ligands, but it was all being mopped up. Now, suddenly the mop is gone. You get this massive flood of unopposed rank ligand.
The dam breaks.
The dam breaks, and all those osteoclast precursors that have been waiting patiently in the wings all wake up at once. You get this huge synchronized spike in bone resorption.
What does that mean for the patient?
We have seen patients stop denosumab and lose all of the bone density they had gained over years in less than 12 months. Even worse, they can suffer multiple spontaneous vertebral compression fractures. It can be a catastrophe.
But it's unlike bisphosphonates, where you can take a drug holiday. Denosumab is more like a marriage.
It is a strict commitment. The current thinking is that if you start it, you cannot just stop it cold turkey. If you need to discontinue it for some reason, you must transition the patient to another anti-resorptive, usually a bisphosphonate, to seal in those gains and protect the bone during that dangerous rebound phase.
That is such a critical clinical pearl. Okay, let's pivot. Everything we've discussed so far, bisphosphonates, denosumab, they're all anti-resorptive agents. They work by stopping the loss. But can we actually put bone back? Can we build?
We can. This is where the anabolic agents come in. And the first one we had is one of the great paradoxes in all of pharmacology. We use PTH.
Wait a minute. PTH, the crisis manager, the guy whose entire job it is to strip the bank vault. We're going to use that to build bone.
The very same one. This is where the concept of timing and exposure becomes the drug. We talked about how continuous high levels of PTH, like you'd see in a patient with a parathyroid tumor or severe kidney failure, absolutely strips bone. But it turns out if you give PTH as a daily subcutaneous injection, a sharp spike that only lasts for an hour or two and then goes away, it has a completely different effect.
The intermittent effect.
Exactly. That transient spike seems to stimulate the osteoblasts more than it stimulates the osteoclasts. It actually reduces osteoblast apoptosis, so it keeps the builder cells alive longer. It changes gene expression to favor formation. It improves the microarchitecture of the bone. It essentially tricks the system into a building mode without triggering the full-blown demolition sequence that comes with sustained exposure.
That is just wild. So the drugs, teriparatide and abaloparatide, these are the PTH analogs, they're actually building new quality bone structure.
They are. They are thickening the trabeculae, the little struts inside the bone. They are reconnecting the scaffold. The bone density gains are impressive, but there is a catch. We usually limit their use to about 2 years maximum.
Okay, why the time limit?
There are two main reasons. The first is a safety signal that came out of the initial rat studies where very high doses given for a long time caused an increase in osteosarcoma, which is bone cancer. We have not really seen this signal translate to humans in decades of use, but the black box warning remains, and it makes people cautious.
And the second reason?
The biological reason is something called the anabolic window.
The anabolic window, what's that?
It means that the effect doesn't last forever. Eventually, even with intermittent dosing, the osteoclasts seem to figure out what's going on. They catch up, resorption starts to rise to meet the new high rate of formation. So you have this window of time, about 18 to 24 months, where formation is winning. You're net positive. You have to capitalize on that window.
And then what do?
You have to lock it in. If you stop teriparatide after 2 years and do nothing else, that new bone that you've built is metabolically active and it's actually quite fragile. It will be resorbed very rapidly. So you must follow a course of an anabolic agent with an anti-resorptive, like a bisphosphonate or denosumab, to properly mineralize and preserve that new density you worked so hard to build.
It's like pouring concrete. You pour it, which is the anabolic phase, but then you have to let it cure and you have to protect it, which is the anti-resorptive phase.
That is a perfect analogy. The sequencing matters immensely.
And finally, in this category, we have the new kid on the block, romosozumab, the sclerostin inhibitor.
This is the drug that came directly from studying those patients with the rare genetic disease. It is a monoclonal antibody that is designed to bind to and inhibit sclerostin.
So it's an antibody that tears down the body's natural stop building sign.
It releases the brake on the Wnt pathway. And when you do that, you get a massive, rapid increase in bone formation. But here's what makes it unique. It also seems to decrease bone resorption at the same time. We think it might change that OPG-NKL ratio in favor of OPG.
So you get the best of both worlds. You're pushing the build accelerator and hitting the destroy brake simultaneously.
For about 12 months, yes, it's considered a dual effect agent. After a year, the formation effect starts to wane. But the gains in bone mineral density that you see in that 1 year are spectacular. They're significantly greater than what you see with teriparatide or any of the anti-resorptives alone.
But there's always a but in pharmacology.
There's always a but. And with romosozumab, it's the cardiovascular signal. In the pivotal clinical trials, there was a small but statistically significant increase in the rate of major adverse cardiac events, heart attacks, and strokes, in the group that got romosozumab compared to the group that got alendronate.
So it now carries a black box warning.
It does. It states that you should not use it in any patient who has had a heart attack or a stroke within the preceding year.
Do we have any idea why that happens? What's the mechanism?
We don't know for sure, but the thinking is that, remember, the Wnt pathway isn't just in bone, it's used all over the body, and sclerostin might have a protective role in the vasculature, perhaps helping to keep calcified atherosclerotic plaques stable. If you take that break away systemically, maybe you destabilize those plaques. It's a potent reminder that these targets are not exclusive to the skeleton.
That's classic systems thinking. Which brings us perfectly to our final section. Clinical integration. We have all these amazing tools now, the old guard, the snipers, the builders. How do we put them all together?
Sequencing is the new frontier in osteoporosis management. For a long, long time, the standard approach was just to put everyone on a bisphosphonate first. They're cheap, they're oral, and they work pretty well.
But that's changing for high-risk patients.
It is. For patients who are at very high risk of fracture, the data now strongly suggests an anabolic-first strategy.
Build, then maintain.
Exactly. The reason is something called the blunting effect. If you start with a powerful anti-resorptive like a bisphosphonate, you suppress the bone remodeling so much, you put all those bone cells to sleep or you kill them. If you then try to come in later with an anabolic agent like teriparatide, it just doesn't work as well.
The cells aren't there or aren't responsive enough to build.
The builders are asleep on the job. So the modern approach is, for the right patient, build the scaffold first while the cells are fresh and active, and then come in with your anti-resorptive to paint it with the preservative and lock in the gains.
That makes perfect sense. Now, before we wrap up, we absolutely have to talk about one specific pathological spiral that both Kutzung and Goodman and Gilman dedicate significant time to. It's really the worst-case scenario for this entire system, CKD-MBD.
Chronic kidney disease mineral and bone disorder. This is just a tragedy of broken feedback loops. When the kidneys fail, the two main managers we talked about, vitamin D and PTH, go completely off the rails.
Can you walk us through that downward spiral?
It starts with the failing kidney. Step 1. The kidney can't excrete phosphate properly, so phosphate levels in the blood start to rise. Step 2. The failing kidney loses its 1-alpha hydroxylase enzyme, so it can't activate vitamin D.
So you can't absorb calcium from the gut.
Right. So now you have a situation with low blood calcium and high blood phosphate, a disaster scenario.
And the parathyroid gland sees that low calcium and just panics.
It panics. It starts pumping out massive amounts of PTH to try and correct the calcium. This is called secondary hyperparathyroidism. The PTH screams at the bone to release calcium, which it does, but it also screams at the kidney to dump phosphate. And the kidney can't hear it. It's broken.
So the phosphate just stays high or goes even higher.
Exactly. And the high phosphate then binds with the calcium that's being released from the bone, which lowers the free calcium even further, which makes the parathyroid gland secrete even more PTH. It becomes a vicious runaway train.
And what's the end result for the skeleton?
Devastation, a condition called osteitis fibrosis cystica, where the bone is literally resorbed and replaced by fibrous tissue. It's incredibly painful and leads to terrible fractures. And meanwhile, all that calcium and phosphate is precipitating in the blood vessels, causing a horrific condition called calciphylaxis, where skin and other soft tissues die because their blood supply literally turns to stone.
So how on earth do you intervene in that mess? You can't just give more calcium because the phosphate is already dangerously high.
You can't. The first step is to control the phosphate. We use drugs called phosphate binders, things like sevelamer or lanthanum carbonate, which are basically specialized sponges that you take with meals to soak up dietary phosphate in the gut before it ever gets absorbed.
Okay, stop the fuel from coming in.
Then we often give activated vitamin D calcitriol because the patient's own kidney can't make it. But the most clever drug we have for this is called cinecalcet.
Calcimetic.
The calcimetic. It mimics calcium. This is a drug that targets the sensor itself. It binds to the calcium-sensing receptor on the parathyroid gland.
And it tricks the gland.
It tricks the gland into thinking that the serum calcium level is higher than it actually is.
So the gland just relaxes.
It relaxes, it shuts down PTH production, it thinks, oh, looks like we have plenty of calcium now, I can stop screaming at the bone. It beautifully breaks that vicious feedback loop without actually raising the patient's calcium and risking more calcification. It's a wonderful example of targeting the information processing of an organ rather than just the substrate.
This has been absolutely incredible.
Yeah.
We've gone from the 10,000-fold calcium gradient to the indestructible PCP bond to the antibody sniper and now to tricking a hormonal gland with a molecular mimic.
It really does highlight that pharmacology in this area isn't just about fixing a level. It's about intervening in a dynamic, flowing, information-rich system.
So let's try to bring this all home. What are the big overarching takeaways for the listener to walk away with?
I think the first one has to be the timeline. This is slow chemistry. These drugs and these diseases operate on a scale of months and years. Patience and adherence from the patient are absolutely key. You can't just take a pill for a week and expect to fix osteoporosis.
Okay, timeline is number one. Second.
The trade-offs. We have incredibly potent drugs now in denosumab, romosozumab, but that potency comes with risks. Rebound risks, cardiovascular signals. The older bisphosphonates are incredibly safe and cheap for the most part, but carry that long-term risk of freezing the bone too much. There really is no free lunch in pharmacology.
And the third takeaway.
I think it's the balance. You have to remember you are managing a living system. And for that system, Ion homeostasis, keeping the heart beating, the nerves firing, is the #1 priority for immediate survival. Bone density is a luxury. Our therapies are all about trying to convince the body that it can afford the luxury of having strong bones even as it gets older and the system gets a little less efficient.
And what should the listener do now?
Go back to the books, seriously. Read the chapter on bone mineral agents in Katsung to get the clinical protocols down cold. Then read the chapter in Goodman and Gilman to really appreciate the molecular beauty of the RNKL pathway and the WANT system. This conversation was just the map. The real treasure is in the text.
I want to leave you with one final thought to mull over. We started this conversation by calling bone a memory, a living record of our metabolic life. When we use a drug like a bisphosphonate, we are, in a way, embalming that memory. We are freezing the history of the bone in place to prevent it from crumbling away.
It's an interesting way to put it.
It makes me wonder, by preserving the structure so rigidly, are we sacrificing the bone's ability to learn from new stresses? If we freeze the archive, do we stop the skeleton's ability to write the future story of its own resilience?
That is a profound question. We preserve the frame, but perhaps we lose some of the living tissue's adaptability in the process.
Something to chew on. Thanks for diving deep with us. We'll see you on the next one.